We're now going to move into the last session, which is going to be focused on genetics and early detection. First speaker will be Jessica Everett, who's a very talented genetic counselor and clinical assistant professor of surgery and a nationally prominent expert on high-risk pancreatic cancer. Jessica?
So I think we wanted to round out by talking a little bit about, as Dr. Simeone mentioned, how are we going to get better at detecting pancreatic cancer earlier so that we can really hit that goal of improving long-term survival in patients with pancreatic cancer. And so Dr. Khanna and I are going to talk a little bit about identifying patients at high risk for pancreatic cancer, because that's really the group of people where we're going to need to focus our research efforts to develop an early detection test that works, and hopefully then eventually be able to spread that out into the wider population. So I'm opening here with a list of risk factors for pancreatic cancer, which include many things that are not hereditary, but for the purposes of tonight's discussion, we're going to focus on what do we know about genetics and pancreatic cancer. What are some of the inherited risk factors that we know about or have been learning about over the past few years? So I'm going to give you sort of a whirlwind tour of these things. I mentioned diabetes here at the beginning, or sort of pulled this out of the other list of risk factors, primarily because, as I mentioned, when we think about early detection studies and where we want them to go, we're going to focus a lot of that work in patients who have genetic high risk, but then eventually people with new onset diabetes is another population of patients where an early detection test would be potentially very useful and would impact a much broader segment of the population. So I think it's just worth mentioning that that's one to pay attention to and an area where we'll want to be moving as we go forward. Also, just want to mention, I know one of the questions that came up already was, what about having a family member with pancreatic cancer? What does that mean to me? And I don't know that you're going to know the answer to that question by the time I'm done with my slides, but I haven't forgotten about you, and we will definitely address that before we are finished tonight. So we've known for a long time that there's some hereditary component to pancreatic cancer. About 5 to 10% of patients who have a diagnosis of pancreatic cancer have a first-degree relative, so that means a parent, a sibling, or a child who has pancreatic cancer as well. And we know that your risk for pancreatic cancer goes up the more people in your family there are who have had pancreatic cancer. There are several known hereditary cancer syndromes that increase risk for pancreatic cancer. Many of them are better known for causing other types of cancers, and I'm going to run through a list of what we know about those. And then I think the other thing that's been really interesting to us from a clinical sense is more recent changes in the technology that we have to be able to do genetic testing for patients and families has led to the cost dropping and to the ability then for us to use these genetic tests more broadly than we have in the past. And so what we are finding is, you know, the more patients with pancreatic cancer we test, the more patients we find who actually carry an inherited risk factor for cancer that might run in their family. And that often those patients don't have an obvious family history that would have led us to do the genetic testing in the first place. So some of the more recent work that's been done in this area suggests that as many as 12% of patients with pancreatic cancer have an inherited risk factor that probably influenced their pancreatic cancer and that other people in their family could then carry as well. And then those other family members who might carry that gene are of interest to us when we think about early detection and prevention efforts. So I wanted to start with syndromes that are likely to present with other findings. These are some of the less common hereditary conditions that cause pancreatic cancer, but they cause some of the highest risk, and so they're worth talking about. One of those is hereditary pancreatitis. So we've heard a lot tonight about inflammation. And this is a situation where what is inherited in the family is actually a gene that causes a situation where you have chronic inflammation, pancreatitis, which is a painful and pretty debilitating condition. And then over time, having that constant inflammation of the pancreas causes the risk for cancer to be quite high. So for people who carry this gene and have symptomatic pancreatitis, the lifetime risk of developing pancreatic cancer is as high as 40%. So it's one of the highest risk factors that we know about. There are other genes that influence risk of pancreatitis, and we know less about their link to pancreatic cancer. And as I mentioned, this is not a common cause of familial pancreatic cancer, and typically in these families there's a pretty well-established history of people having to be hospitalized with their pancreatitis. This is another really rare condition. Even those of us who see really rare stuff have maybe only seen a handful of patients with this, but again, one that is associated with a quite high risk for pancreatic cancer. It's called Peutz-Jeghers syndrome, and it's caused by a gene called STK11. These are patients who have physical findings that we can typically appreciate. They're most prominent in childhood and often go away as people get older, and I'm showing you a couple of those things here. They get freckles in places that you wouldn't expect people to get freckles. So they happen on their lips and inside the mouth, and then also on their fingertips and around their belly button in places where people don't normally get freckles. So that's usually a dead giveaway for patients who have this, although as I mentioned, sometimes we have to ask people, did you have these when you were a kid? Because they can fade over time. The other thing that these patients will typically present with is another type of polyp in the small intestine that can cause the small intestine to collapse on itself in a way that is dangerous and painful, and so that's often how these patients end up getting diagnosed. Separate from all of that, in people who we know have this diagnosis, the lifetime risk of pancreatic cancer is up to 36%. So again, from an early detection and screening standpoint, even though these patients are rare, it's really important for us to identify them to make sure that we're doing what we can to screen them for pancreatic cancer. This is another one that is fairly clinically obvious in other ways that have nothing to do with the pancreas. So this is familial polyposis, a condition where people get hundreds or thousands of these little polyps, the adenoma type polyps that are precancerous in the colon. There are some cancers that can happen outside of the colon in patients who have FAP, and one of those happens to be pancreatic cancer. So once we get them through the risk of their polyposis, which often means we have to remove their colon completely, then we need to keep an eye on them for some of these other things. More interesting to us at the Pancreatic Cancer Center from a clinical perspective is what about the syndromes that maybe weren't diagnosed before somebody shows up in the clinic with pancreatic cancer? And it turns out that there are more of those than we had maybe previously appreciated. And I think that's partly because for many years, everybody was really focused on, do you have a family history of pancreatic cancer? And we're really only paying attention to those families where multiple people had pancreatic cancer. And it turns out that if you cast a wider net, you will often find that patients with pancreatic cancer have family history of other cancers that are actually connected and that can tip us off to a possible hereditary risk. One of the big ones, and one of the most common ones, is hereditary breast and ovarian cancer. How many people have heard about this one? A lot of you probably. It's hard to not hear about it. So these are the breast cancer genes, BRCA1 and 2, that are best known for causing high risk for breast and ovarian cancer. But it turns out also increased risk for pancreatic cancer. And I think this is going to be an interesting thing to pay attention to over time. Again, now that we've gotten better at early detection and prevention for women with BRCA1 and 2 mutations, and we're keeping them alive and not having them die from breast cancer or ovarian cancer, now we have to be more alert to the other kinds of cancers that we can see in people who live a long time with these mutations. I think this one's also worth mentioning specifically for our population here at the Pancreatic Cancer Center, because we know that if I didn't know anything else about you except you're Eastern European and Jewish, you have a 1 in 40 chance of carrying a BRCA1 or BRCA2 mutation. You may or may not have any family history of cancer to suggest that. So in patients we see who have pancreatic cancer and have Eastern European Jewish ancestry, we are always thinking about BRCA1 and BRCA2 as a possible factor for their pancreatic cancer. This one's also relevant because it turns out that BRCA1 and 2 status makes a difference in thinking about treatment options, because there's a particular therapy called PARP inhibitor therapy that seems to be more efficacious in patients who have BRCA1 and 2 mutations, so it's relevant from that perspective as well. Another one that can present in the clinic in a patient with pancreatic cancer is this condition called familial atypical multiple mole and melanoma syndrome, which is a mouthful. Hereditary melanoma is really what this is best known for, and the gene for this one is called CDKN2A, or P16 is the protein that you sometimes hear associated with this. So again, this one is best known for causing high risk for melanoma. Although not everybody who carries the gene gets melanoma, and in many of these families we see patients with pancreatic cancer. The risk for this one was really best studied in the Dutch population, where there's actually a very common mutation or change in the P16 gene that's present in a large enough section of the population, so they all have the exact same genetic change. And in that population, risk of pancreatic cancer in carriers is up to 17%. So again, this is one of the higher risks for pancreatic cancer. There's still a lot that we don't know. So for example, if you're a person with a CDKN2A mutation that's different from the one that's common in the Dutch population, is it really 17% or is it less than that? We certainly have many families with this gene where no one has pancreatic cancer, so there's still a lot for us to learn. But these are patients and families where we think it's worth talking about early detection, as Dr. Khanna is going to describe in a moment. Lynch syndrome, this one is relevant because you've already heard a little bit about this one this evening. So these are patients who have an inherited mutation that causes what's called mismatch repair deficiency. So these are the patients that were the sort of special responders to the immune therapy that you heard about earlier. And that can happen because of a hereditary reason, which is Lynch syndrome, or sometimes it's specific just to the tumor. And so again, these families are better known for having high risk for colon cancer and uterine cancer. So those are usually the top two things that we see in these families. But pancreatic cancer risk is also increased. And by the age of 70, risk for pancreatic cancer in these patients is about 4%. So not huge, but again, I think will be potentially very important for us to identify these patients because it makes a difference in how we think about treatment options for them, and it makes a difference in understanding what their prognosis is for their pancreatic cancer. Also interesting, over the past few years, we've seen some newer genes that have been described as being linked to pancreatic cancer. Some of them, again, had been already out there as genes related to risk for other things. So the first one on the list is called PALB2, and that got named there. It's a partner and localizer of BRCA2. So it works in the same pathway as BRCA1 and 2. So researchers have been really interested in that gene for a long time because they knew mutations in the other genes that work with it cause high risk for breast and ovarian cancer, and so we're pretty suspicious that it might be a problem child as well. So again, focusing on patients with familial pancreatic cancer, where 2 or more people in the family had pancreatic cancer, somewhere between 1% and 3% of those families will have a PALB2 mutation, and not surprisingly, it's linked to increased risk of breast cancer as well. ATM is another gene that we've become pretty interested in our group recently. Again, this one has been known as a moderate risk gene for breast cancer, so it may about double your risk for breast cancer compared to a woman in the general population. And it's not rare, so probably about 1 in 100 people is a carrier of an ATM variant, but what we started to see was in patients with pancreatic cancer when we were doing testing in the clinic, that we were seeing more carriers of ATM than we would expect by chance alone. And again, studies that were looking at, okay, here's a family with multiple patients with pancreatic cancer, let's sequence their entire genome and see if we can identify a new cause for pancreatic cancer, popped up a few families that had ATM. And so we're still trying to figure out exactly how it influences risk and why it's so common in the population, but not causing pancreatic cancer in all of the people who have it, so there's still more for us to learn. And similarly, more recent studies that have started popping up more carriers of a gene called CHEK2 than we would expect by chance alone. Just like ATM, it's been out there as a gene that has about a 2-fold increased risk for breast cancer. And we're not sure why it's popping up more in our patients with pancreatic cancer, but it's another area for us to pay attention to. I think the group that we struggle with the most, though, are the patients and families where more than one person in the family has pancreatic cancer, and we hit you with all the genetic testing we know how to do, and we find nothing. And then we're sort of left with saying there's probably some sort of shared risk factor in your family that just has not been identified yet. And so we'll call that familial pancreatic cancer. So these are families where 2 or more people have had pancreatic cancer. There's no identified genetic risk factor. And then we typically think about screening for these patients and families depending on how many close relatives are affected. So I've kind of broken it down for you there. And I mentioned before, the risk for an individual in one of these families depends on how closely related you are to how many people. So the more close relatives you have, and this is sort of common sense, the greater the chance that you share some genetic risk factor with all of those people that might increase your risk. I mentioned earlier that one of the big changes in my world as a genetic counselor has been with the development of next generation sequencing for genetic testing. What has happened is the cost to do genetic testing dropped dramatically, and so our ability to test a lot of things for more people for less money than it used to cost us has led to many people using testing more broadly. And what we're discovering is there's a lot of stuff we didn't know that we thought we knew, including, as I mentioned before, that if we focus genetic testing only on people who have strong family histories, where we can say, okay, there's breast and ovarian and male breast cancer and pancreatic cancer, this looks like BRCA1 and 2, so you get genetic testing. If we go more broadly, we're finding more patients who end up having a hereditary risk factor where there isn't an obvious family history. So I've mentioned that somewhere between 4% up to maybe as high as 12% of patients with pancreatic cancer have an inherited or germline finding that's relevant for their family members and sometimes relevant for their own care. The difference or the variation there depends on how many genes you look at when you do that multi-gene panel. So bigger panels, obviously, you're going to have more hits there. And most importantly, we've spent a lot of time focusing on what's in your family history to help guide our genetic testing. I'm a big believer in the importance of family history, and I don't mean to say it's completely worthless, but I do think it's important to recognize that not everyone who carries a gene who has pancreatic cancer has an obvious family history that would have led us to do genetic testing in the first place. So I think it's really moved us to a point in time where we think it is important to consider genetic testing for any patient we see who has a diagnosis of pancreatic cancer. And we are currently offering that under a research protocol to our patients here at NYU, but there are many clinical sites across the country who have started to adopt that practice as well. And I think it's important because it will help us to increase identification of family members. So as a geneticist, I always think about a family as my patient. And if we identify a genetic risk factor in a person who already has cancer, we want to try to do better for the other people in the family. So we want to identify the people who haven't had a cancer yet but are at risk, and then try to intervene and detect things early or eventually prevent them. So that's really our goal. And I think doing more broad genetic testing is really going to help us to increase identification of people who could benefit from screening. So that's just a list of all the criteria that I mentioned to you already, and I'm going to tag Dr. Khanna in now to talk about, okay, once we identify these patients, what do we do to take care of them?
So just to introduce Lauren, she's a very talented clinical assistant professor here in gastroenterology with expertise in pancreatic diseases.
So we're going to move on to talk about screening or early detection of pancreatic cancer. So just as a general principle, there are sort of established criteria for when we should do screening tests. In pancreatic cancer, it's particularly important that we would be able to identify something at a sort of asymptomatic or early symptomatic stage, and that there's a test that we can use. As we discussed earlier, the overall 5-year survival of pancreatic cancer is not that great. It's 9%. It has been creeping up 1% a year over the past few years due to perhaps our earlier detection and also our better treatments. But the biggest issue is that most patients are diagnosed at a late stage. And as someone asked earlier, pancreas cancer is often asymptomatic until it's grown quite large or spread. And so, unfortunately, it's very difficult to detect by symptoms alone. And so that's why we see that about half of the patients that are diagnosed have already had their cancer spread outside of their pancreas to somewhere else in their body. And we know that survival after pancreatic cancer is directly related to what stage of presentation a patient is at. So in patients who have spread of disease, their 5-year survival is very poor, but patients who have very localized or small tumors have the best survival. So our goal by screening or early detection is to detect earlier or smaller tumors so that we can move patients who do have a cancer to the higher survival side of our graph. In terms of screening tests, we've discussed that right now high-risk individuals are the most important people for us to screen. The reason for that is that although it's a terrible disease, the overall incidence is still quite low. The general population risk of developing pancreatic cancer is 1.5%. And so if we were to screen everyone using screening tests that are not perfect, we may detect a lot of people who have a false positive test, and they may have sort of invasive or invasive procedures or things like that that would be difficult. And so we really try and target our focus right now on high-risk groups until we perhaps develop better tools to detect or do screening in everyone else. So what are our targets of early detection? So we really would like to shift that curve to detecting cancers that are early, like we said, localized. There's one Japanese case series of tumors on less than 1 centimeter where there was 100% cure with surgical resection and possibly other therapies. But overall, we'd really like to shift that 50% of patients who are already metastatic at the time of presentation so that we're detecting small or localized tumors. The other thing we really want to try and detect are precursor lesions. So there's 3 types that we generally think about. And I'll go through PANNs and IPMNs because those are especially the targets of our sort of screening or early detection programs at the moment. So PANNs are pancreatic intraepithelial neoplasia, and Dr. Miller had a very similar diagram in his presentation, and it shows this stepwise progression with increased genetic defects of the lining of the ducts in the pancreas. And it's very similar in colon cancer. We think that polyps gain genetic mutations and turn from just a regular benign polyp into a cancer. And we think that a similar process happens in the pancreas. Unfortunately, though, in the pancreas, these changes are detectable only microscopically at the moment. And so we don't have a great test to detect PANN lesions at this time. What we typically find by our screening or early detection programs are IPMNs, which are intraductal papillary mucinous neoplasms. So they're changes of the ducts or the tubes that drain the pancreas, or dilations of those tubes, or large cystic fluid collections. And so we see them much more easily on imaging. And so here we can see this is a diagram of the main tube of the pancreas. So this is a main duct IPMN. Those tend to have more malignant potential. And then there's also, the bottom diagram is a side branch IPMN where it's coming off of the main duct. And so we know that there are certain features that are associated with increased risk of malignancy, greater size, nodularity, if they have a sampling and it shows that there's malignant cells, and then also any dilation of the main pancreatic duct. So those are definitely good targets for screening. So what tests do we have now to assist us in our early detection efforts? Really the only tests we have at the moment are the tests we use to take care of those patients with pancreatic cancer. So the blood test that we have is the CA19-9, and then our imaging tests are CAT scans, MRIs, and endoscopic ultrasound. So CA19-9 is a tumor marker that we use frequently in patients with pancreas or bile duct malignancies. In patients who have a tumor, The sensitivity of that test is about 80%, meaning not all patients who have even one of those tumors have an elevated level of CA19-9. And that's partially because one of the blood types doesn't ever express this marker. And the specificity for the marker is it's not perfect either. It's only 80 to 90%. So overall, it has a low positive predictive value. There's a percentage of the population, 5 to 10%, who will never express this marker. And then there also are people who would have a falsely positive elevation in the CA19-9 because there's many other things that can cause an elevation, diseases in other organs like the thyroid. And so it's not a great marker overall. In terms of imaging, CAT scan is probably the most frequently used imaging that any patient has, particularly if they go to the emergency room or have abdominal pain. And it is the most frequent modality probably by which we diagnose someone with pancreas cancer. But in terms of thinking of a screening or early detection test, it's not an optimal test. It's not great at detecting smaller lesions, which are really our target. And so even tumors that are up to 2 centimeters, it's only 65 to 75% sensitive to find them. It's also not particularly good at finding pancreas tumors in the setting of pancreatitis. And as we discussed in a lot of these talks, inflammation can be a precursor to pancreatic cancer. Patients who have pancreatitis have an increased risk of pancreatic cancer. So it's a difficult modality. And then the greatest flaw in terms of doing a screening test is it has a lot of radiation exposure. So if we are considering to look at patients on a yearly basis, that's a lot of radiation, and we might have a risk of actually secondary cancers as a result of screening. So MRI is generally used because of that. It has no radiation, and it can detect somewhat smaller lesions than CAT scan. That said, it's a much more expensive test. It's a longer test for the patient, and some patients are unable to get MRIs. Some are claustrophobic, and some have other medical contraindications like metal in their body. Endoscopic ultrasound is a procedure where someone has an endoscopy and they have a special tube with a camera with ultrasound at the end, and we use it to look at the pancreas. It's the most sensitive test for detecting pancreatic lesions, especially small ones, but it's an invasive procedure. It usually requires sedation or anesthesia, and it's only done usually by gastroenterologists with special training, and it's not always available in many settings. It's also not perfect. In each patient, there may be some blind spots where we can miss things during this test. And just like CAT scan or MRI, in the setting of pancreatitis, it can be difficult to sometimes find tumors. So I wanted to discuss some of the high-risk screening programs that have reported their outcomes. There's probably about 10 to 15 studies in the literature, so I'm just going to talk about a few of them. This is one that came out of New York City, out of Columbia. This was a program where they enrolled 51 patients that they reported on. All the patients had a meeting with genetic counselor, and if applicable, they underwent genetic testing. Patients who they considered moderate or high risk for pancreatic cancer had endoscopic ultrasound and/or an MRI. And so what they reported was that of the 51 patients, 4 of them were found to have either pancreatic cancer or at the time of surgery to have PANN2, which is sort of midway through that precancerous progression. And interestingly, they had patients who, because they went through the screening process and had genetic testing, were found to maybe have BRCA or a different mutation. They had screening in their other organs, and they found ovarian tumors or thyroid tumors. So they had some other findings that helped the patients, as well as detecting these pancreas lesions. This is the CAPS consortium. It's a multi-center prospective cohort that involves Hopkins, Mayo, UCLA, Dana-Farber, and MD Anderson. And so this was a report they put out in 2012. So at this multi-center study, they had 200 plus patients who enrolled, and every patient underwent MRI, CT, and endoscopic ultrasound. And among those patients, they said that the yield for a pancreas lesion that was found was 42%. And as you can see here, so 57% had no lesion. Many of them were found to have pancreatic cysts. And and a couple were found to have solid lesions in the pancreas. So many of the cysts that we find that look like these IPMNs are thought to be benign unless they have those high risk factors. So very few patients among this large number that had a pancreas lesion actually went to surgery. So 5 of 216, or about 2%, they went to surgery. And all of the ones that were well selected for surgery were found to either have IPMN or a PAN-IN grade 2 to 3, so towards the precancerous side. And then this is one of the more interesting studies that just came out. This is a multi-center cohort in Europe across Spain, Germany, and the Netherlands. And so they really targeted these high-risk individuals with specific genetic mutations, like Jessica just went through. And so at each site, the patients had an annual MRI, and they had an endoscopic ultrasound differently depending on the site. And among the CDK and 2A mutation carriers, they found 7% of them to actually have pancreatic cancer either at the initial screening test or during their follow-up surveillance. 75% of them underwent resection, and this is the most impressive part of this study and makes it very exciting for us to do these high-risk screening programs, is that the 5-year survival among these patients was 24%. So most of these lesions were found at an early stage, and so these patients had a 3 times increased rate of 5-year survival compared to the average general population. They also found a couple tumors among patients who had familial pancreatic cancer, and they found 1 tumor in a patient with BRCA, and they found sort of precancerous lesions among the familial pancreatic cancer and breast ovarian cancer risk syndrome patients. So we're very excited to start a high-risk program here at NYU, and we have excellent genetic counseling, and we're also utilizing MRI and endoscopic ultrasound. But the things that we're very excited for is to start to employ new tools for early detection. What I've discussed so far are what we currently have, but we'd like to work on, as part of our research, things that are coming up. So there are numerous reports, many of them out of different sites or different labs, of many different things that we can look at. And so I'm going to just go through a few of them. So there's thrombospondin 2. So this was a recent report of trying to find a serum marker that we could use. Because, when we think of the different testing modalities, the easier it is for the patient, the better it is for all of us, because patients will be more likely to have it and more happy to have it. So serum biomarkers would be the most exciting area to work in. So this group looked at a variety of proteins, and they found this to be a potential target. It's involved in TGF-beta signaling and integrin signaling. And they went through a lot of different studies in animals to try and come up with the biologic plausibility. But at the end of the day, what we want to know about it as a marker is how well does it distinguish people with pancreatic cancer from normal controls. And so it worked best in combination with CA19-9, which we had discussed earlier. It was 87% specific, 87% sensitive, but very specific, 98% specific for pancreatic cancer and patients with cancer compared to normal controls. And what's very exciting is that it was able to distinguish very early lesions, stage 1 resectable lesions, versus a normal control. And it wasn't only the patients with metastatic disease that were picked up as positive by this marker. But this is a first test, and it needs to be validated in a larger cohort. Circulating tumor cells or circulating pancreatic cells are a very exciting area as well. This came out of work where they were doing studies of mouse models of pancreatic cancer, and they found in the mice with PAN-INs, so not even invasive tumors yet, that they could detect these pancreas cells circulating in the bloodstream before the mice had actually developed an invasive cancer. And so this raised the question of whether or not this is something we could use in humans. So the human study that was done by the same group in 2014 looked at patients with pancreatic cancer, patients with cysts, and patients without any pancreatic cancer or cysts. And they found that 73% of patients with cancer had these circulating pancreatic cells. 33% of the patients with cysts had them as well. And none of the patients with sort of normal pancreases had circulating cells. We don't really know the details about how malignant those cysts were, so there's still a lot we have to learn with regard to these, but it's a very promising area for the future. This is another exciting area. This is IMMray or Immunovia. It's a microarray platform, so they use antibodies to map any circulating cancer-associated proteins or immune-regulated responses. And so this, as it started with researchers who developed a company, and they went through many different markers and have narrowed it down to a panel. Their initial study, which is published, was among 200 patients in China, about 100 pancreatic cancer patients and 95 controls. And at every stage of pancreatic cancer, this test could distinguish the cancer patients from the controls, especially importantly for us in thinking about screening, the stage 1 or stage 2 patients could be distinguished from normal controls pretty well. And so we're excited that that will be part of something that we'll work on here along with many other centers to help try in our population. There are some other more non-serum based tests. One that's interesting is testing pancreatic juice. And so there are studies of patients who have had endoscopic ultrasound and had juice collected from the small intestine where the pancreas drains at the time of the ultrasound after they get an IV medicine to increase pancreatic secretion. And so groups have looked at various different mutations. And so this is among the CAPS group, that multi-center site, and they found that in patients with pancreatic cancer, many of them had increased P53 mutation, and they also found that among patients with PANN lesions. People have looked at pancreatic juice for some other mutations like KRAS and found it not to be helpful, and then out of the Mayo Clinic, they've looked at methylation markers in the pancreatic juice, which is also they found one that at least is interesting. So I think we'll learn more about that, but it would be something that would be paired with an already invasive test so that people wouldn't have to have an additional invasive test. So it's not as wonderful as a serum marker. And then another potential avenue is stool DNA testing. This is something that we've started researching in colon cancer to look at gene methylation markers. And so there has been some work in pancreas as well to see if there are any DNA mutations that can be detected in the stool that would signify an increased risk of pancreatic cancer. And so a group at Mayo Clinic has looked at that. They identified down here the methylated BMP3 as the most sort of upregulated DNA mutation found in the stool of patients with pancreatic cancer. And so when they paired that with KRAS as well, they found the best sensitivity and specificity for detecting pancreatic cancer, but there's still a lot of work to be done in this area. So I think in terms of screening and early detection, there are a lot of questions left to be answered. Right now we're discussing screening in high-risk individuals, and so we're also trying to redefine those target populations as we get more results from genetic testing, but also about environmental risk factors and personal risk factors like diabetes. A very important question is when people should start screening. Some programs start at age 50, some start at age 40, some start 10 years before the diagnosis of their family member with pancreatic cancer. And so I think that's a question that we have a lot left to learn about. How to screen, as we've discussed, we have some modalities that are available now, but we're hoping that we'll have more tools down the road. And then how often? Right now, most of the studies are doing annual MRI or endoscopic ultrasound, but should we be able to incorporate serum markers? Would that change our frequency of invasive and expensive tests? So there's a lot of questions to be answered. When we find these lesions, it's a very difficult decision whether or not someone should undergo a pancreas surgery when you may have a precursor lesion and you're not sure if it's malignant. You may be over-treating some people, but you may have also prevented a cancer that could have developed 10 years down the road. So it's difficult to determine what outcomes are success. If we find a precursor, is that a success? It's hard to know if we've taken out their pancreas, but perhaps we actually have helped them. Certainly when we find early cancers and can increase their survival, I think we would all consider that a success. And then how to do surveillance in patients who have been high risk and found to have a lesion. We really have no experience in how closely we should watch them and how to watch them. So maybe I can invite Dr. Simeone up to sort of sum up what we're going to consider for the future.
So, just to kind of wrap up, in thinking about future directions to consider, and you've heard Lauren and Jessica give a terrific job about, how we really go after defining the high-risk population. And I think based on some of the concepts we presented earlier, Precision Promise, perhaps there are lessons learned about how to develop larger scale consortium-type effort to develop early detection blood and imaging tests for in genetically high-risk individuals. What she has shown is a number of individual center studies that are small numbers and really inadequately powered, but if we were to build this out and develop a large cooperative model has been developed for Precision Promise, perhaps we can answer some of these questions. We will likely need thousands of patients to answer these questions. But with such an effort, we will be able to attract new promising technologies. We will test the performance of these tests head-to-head, which is important. And in addition, we can test the performance of combinations of these different technologies. And for any of these tests to be approved for use in patients, the FDA has to be involved. And what we have learned is getting the FDA involved early can provide a great benefit in getting us where we want to go faster. So this will wrap up our session. I just wanted to show this last slide. This has been a terrific session, and you can hear a lot of the exciting work that's being done, not only here at NYU, but nationally. And I'm actually relatively new here at NYU. I've only been here for about 5 or 6 months, but you can see there's really a growing and intense effort to work on pancreatic cancer, and we're very excited to partner with our colleagues around the city and also around the country to provide state-of-the-art care and to move the needle in pancreatic cancer. So thank you very much. If anybody has any additional questions, please feel free to come up and speak to the speakers. We'll be hanging around for a while. Thank you.